Today I'm joined by Mr. Salman Waqar, consultant ophthalmologist at Moorfields Eye Hospital Dubai. Salman trained internationally across Pakistan and the United Kingdom before moving to the UAE, where he now practices as a glaucoma and cataract specialist. He's got a very strong academic and training background with interests in surgical performance, simulation, and clinical governance. Salman Waqar, great to have you with us.
Hi, Simon. Thank you very much for inviting me. It's great to be here.
Salman, thank you so much. You've trained and worked across three very different systems, Pakistan, the UK, and the UAE. Can you tell us a little bit about your consultant career to date and what actually prompted the move to Dubai at that stage in your career?
Uh, Thanks, Simon. Before I answer that, I just wanted to congratulate you on this excellent podcast series as well. It's just so nice to hear from colleagues and peers from all over, very candidly discussing their journeys and and choices, and I think it's a great resource for us as colleagues, but also the next generation of ophthalmologists coming through as well. So thank you very much for bringing it together, and well done on that. To answer your question, so I grew up in Pakistan. After graduating from medical college, as we call it there, I moved to the UK in 2005, did the foundation years, bumbled around in some odd surgical jobs for a bit, trying to get my way into ophthalmology as we all have, and then joined the Southwest rotation down in Devon and Cornwall. And eventually in 2016, joined as a consultant in Plymouth, looking after glaucoma patients, and of course, the usual cataract workload that we all have. And things were ticking along very nicely, took on clinical governance, very nearly was appointed clinical director as well. And then the decision came along to move along to the United Arab Emirates. And that was primarily based on family reasons. My parents, my wife's parents are in Pakistan. And it's quite difficult for them to trek all the way to Devon to see us. And they're getting older, more needs, more requirements for family to be closer to them. And it was just the opportunity that the Moorfields job came along just as COVID had hit. Interestingly enough, that in itself was a big decision to make, leaving a stable NHS job and taking the plunge. But we felt it was the right thing at the right time. And so in 2020, moved to the UAE, and still going strong here.
Wonderful. And let's cut through the polite version. Is life actually better now than it was in the NHS out of interest?
Well, that is a great question. And actually, a lot of people ask me here the same thing as well. And I've often thought about that. Well, firstly, living in Devon is, you're not really comparing lifestyle or work-wise to Dubai. Dubai is a big metropolitan city. It's hyper capitalist, it's hyperactive. The city literally never sleeps, whereas Devon is your rural countryside lifestyle. So I enjoyed that for what it was. I'm enjoying this for what it is. And the same translates into work as well. So whilst in Plymouth, I wasn't entirely working for the NHS. I was also working at the Nuffield. I was also doing the odd high volume cataract list with New Medica or its counterpart in Plymouth. I'd also joined colleagues' private practice in Exeter. So I had spread myself out purely to gain experience on the private side of things, because that's something I felt would be valuable to me. And so it was very fulfilling in that respect. I was not just tied down to one thing. And in fact, somebody that you would remember from your days in Devon, Tim Freegard, when I joined, he was clinical governance lead. So within a week of joining, because there was nobody else suitably junior around, and if Tim ever hears this, I'm sure he'll have a little laugh to himself. The clinical governance role was passed on to me, and so that was a that was a learning curve as well, which I actually thoroughly enjoyed. And so there was a whole lot of variety to my work, even with the NHS and outside of the NHS, which get me very interested. Now, moving here has taken away many of the things that we perceive as negatives whilst working in the NHS. But having worked now across three healthcare systems, effectively seeing how it is in Pakistan, in the UK, and the UAE, and actually having a lot of interaction with a lot of international colleagues here. Our team has people from Spain, Lebanon, Germany, the USA, I've come to this conclusion that no healthcare system really is perfect, and there's pros and cons everywhere. And it's a privilege to be able to experience so many different healthcare systems, and you just take the good for what it is, and kind of tide your way through the negatives. So there are things I don't miss, but equally things that I have come to value a lot about the NHS as well.
Now, stress comes from lots of different angles. It comes from family potentially, and of course, your family is overseas in Devon from where you currently are. But of course, a lot of stress comes from work as well. If we could just compare your work stressors now to how they were previously, is your day-to-day stress level lower now than it was in the UK? Is your blood pressure at work lower than it used to be?
In many ways, yes, and I could attribute that to a few things, which I would say with the caveat that not everybody working in medicine would have had the same experience. So I'm working with a very nice organization. The work environment is very nice, whereas there's uh, a kind of plethora of types of hospitals here as well, where in some the workload is very high, the shifts are very long, and stress levels can be high, whereas other employers are far better. So the things that I really have come to appreciate, and I wish that in the NHS as well, and it used to be, and I wish that it would come back, is simple things such as I have a clinical assistant who's able to help me out with every patient, and by virtue of that, I'm able to see 40 odd patients every day in a private setup. Is there is just efficiency, and you're able to just move through things where the whole experience is better. Um, I have the same room that I use that is mine. It's set up for me, and all of that. I have a lot of control over my clinic, although appointment times are fixed. I have a lot more control over surgical listings, theater sessions, keeping in mind that we are just an eye hospital. This would be a little bit harder if we were part of a multi-specialty hospital. So all of these little things, I think, that do make a difference. When you talk about stresses, the larger stresses, I suppose the great thing is that I don't currently have on calls. So that's one thing that's just not there. Although I did used to enjoy the uh, some aspects of being on call were very interesting and very exciting. So overall, yes, I am more relaxed, but I would view that holistically because I'm closer to family in Pakistan. I think that adds a bit of holistic relaxation. Um, I think I'm a bit more settled in myself as an ophthalmologist, in my career as an ophthalmologist. I think that also adds something to it. Um, that being said, there are a whole different set of stresses that come with the territory. So I would say you swap stress never goes away. You just swap one stress for a different type. And we can touch on that in more detail in terms of dealing with insurance companies and high patient expectations and various other things that do come with the territory as different stresses as well.
And of course, the other thing that causes a great deal of stress is having a missile land on you. And I understand you've had three missile alerts this very afternoon. So I'm very grateful to you for making time to talk to us.
Yes, that's true. And if you do hear a loud sound, that could be the alert. Although the alerts are louder than the actual action because fortunately the setup is pretty good and things are intercepted quite a long way off.
So going back to the comparison, the NHS is very heavily governance driven, protocols, audits, layers of oversight, public self-flagellation and navel gazing. Where you are now, do you feel clinically more free or more exposed?
That's a great question, actually. That is a very nice question. Um, in terms of regulation, again, working across different healthcare systems, in many ways, I've seen things in Pakistan where often there is very little regulation. I've seen the things that can come with that. There are some benefits that can potentially come with that, but more so, there are downsides to it. Um, and then sometimes you can lean into overregulation as well, which is where I think sometimes the UK ends up. And that itself is great for patient safety, but it can also hinder a lot of things as well. Here in the UAE, I think we're kind of sat somewhere in the middle. Um, and there is good regulation from the health authorities. It's not the Wild West. But at the same time, I do feel that I have more control over what I do. And the medical legal aspect of things also is generally more sensibly balanced between patients' rights and what is sensibly a doctor's position as well. So in that respect, I think it is in a nice happy medium place at present. um, we get access much earlier to new tech, new medications, across all medical specialties. I think the UAE generally likes to be perceived as trailblazing in that, so things get moved through to us quicker. The governance, as far as individual hospitals is concerned, when you talk about move away from regulation to clinical governance, that in itself is not a deeply embedded concept. So when I joined here, I think it was just at that time that Moorfields in London had kind of indicated that they wanted somebody on site to manage clinical governance. And lo and behold, I just literally turned up the week this happened. And it was for the second time in my career, very quickly passed on to me because it just seemed like somebody who'd just been doing it. And I thought I'd kind of escaped that, but I kind of found my way back into it. And I have enjoyed it a lot here as well because it's just brought different challenges, different learning experiences. And we've really worked, at least for us, to embed the concepts of clinical governance that we're used to, that we take for granted. Simple things such as, of course, you would audit your practice. It's not quite such a given in many different parts of the world. But once people realize its value, they do understand. So creating that culture as well. So we've been working a lot on that as well.
Looking at the medico-legal side of things, there's a perception, and please correct me if I'm wrong. There's a perception that in parts of the Middle East, the medico-legal environment can be quite binary. If things go well, everything's fine. If things go badly, the consequences can be serious, even jail terms and that sort of thing. Um, how accurate is that in your experience and what you've seen around you?
Well, certainly not in the time I've been here. I too have heard stories. I think in the past in different countries around the region, there would be fairly difficult situations that would happen in the way that you've said. Whereas at least now in the UAE and in particular with Dubai, from what I've seen so far, there is a structure and a system. It's not a system of public prosecution. It's more a system of um, a legal challenge, which means that you don't go into the public prosecution system, so to say, but it actually goes into, well, the patient wants to sue you, so therefore your insurance company therefore has to kind of work with them to figure out a solution. So I have not seen that. I think it's well regulated, and from what I've seen so far, the decision making is quite balanced, keeping in mind simply the fact that there has to be, for the doctors to perform their duties well, there has to be certain common sense and how their actions are perceived as well. And at the same time, very much keeping in mind the patient's rights as well. And also keeping in mind, very importantly, which is something that I've come to appreciate, is the patient's own responsibility to their health, as opposed to something that we used to see that if somebody has not attended many times, there was always an implicit kind of message that we have to try and make the patient attend. Whereas if it's an adult patient and if they're not vulnerable in any way, they also have an onus of responsibility to take care of their own health. And I think that balance I've seen to be quite nicely kept here.
Very sensible, certainly. Does the medical legal situation change how you operate in terms of risk tolerance, patient selection, or even something as specific as lens choice? Are you more cautious?
Not any more than I was when I was working at the Nuffield, for example. So essentially, working here, it's all insurance based, and then there will be self-pay patients as well. And then insurance have different tiers of insurances based on, usually the employer will arrange the insurance. That's mandated by law. So when you come and work here, your employer arranges the insurance, and based on how good your employer is or how good the position you have, you may have access to different types of hospitals. So for us at Moorfields, we get people who are on higher insurance tiers, and also we are a super regional referral center. So people from many other countries, from here, North Africa, and even further down to Nigeria, etc., will refer more complex cases to us, and these are usually self-pay patients. So it's no different to the work that you do in your practice, for example, where the expectations are high, and we cater for that. Medical legally, it does not change anything, because I think when you go back to, what makes us ultimately good at what we do, particularly when we're dealing with more challenging cases and we progress in our careers. I think the ultimate fact is that we cannot shy away and change our decisions based on medical legal reasons. Ultimately, the core question is, would I make this decision irrespective in the benefit of the patient, whether the medical legal imperative is there or not? And so that stands true here as well.
Excellent. And if you strip it right back, what have you gained by moving abroad and what have you quietly given up?
Well, I certainly gave up my mountain biking in Devon, which it's kind of hard to it's kind of hard to replicate in the desert. But what I have gained is working in a different environment, working in a different cultural setup. I've gained by my family benefiting from that exposure. I've gained from being closer to wider family, reconnecting with many people I'd lost touch with. Professionally, I feel I'm very lucky to have had the opportunity to work across so many healthcare systems, because really every time I'm learning something new, and that adds to me as an ophthalmologist. I think there's no doubt about that. There's a whole different bunch of skills that I learned in Devon and then working at the Nuffield or other private setups. I deliberately, there was no need to, but I deliberately put myself in the position to try and just do these high volume lists just to see what it's all about. It's like, how do people get through 22 cataracts a day? And, if they can do it, so can I. And see what that's all about. And here, just learning how to deal with insurance companies in itself is extremely informative, as it's a landscape that we even might see more and more potentially in the UK as well. Um, Dealing with purely high profile self-paying patients, that in itself brings a lot of teaching with it, and managing risk that comes with it. So it's a lot to learn there, actually.
Is it purely private, or do you have opportunities for treating patients who wouldn't otherwise be able to afford treatment where you currently are?
So at present, it's purely private. However, there are hospitals that cater to people who would not be able to come to us on their insurances. And we do sometimes help out with that. That's not something that's very streamlined, but I'm hoping to do more of that in the future.
There's certainly a perception that places like Dubai are not always permanent destinations, more part of a career journey. How do you see it? Is this long term or is it just a chapter in the Sackerverse?
That's so hard to say. I think having moved countries 3 times now, um, in my lifetime, I have no fixed notions about the future. I think I'm just taking it as it comes, and if the future is somewhere else, then so be it. Or we might be having a replay of this podcast many years, and I'm still sat here. You
I
never know.
shall look forward to it, Salman. You sit at that intersection, if you like, between glaucoma and cataract surgery. Has that changed how you think about risk and outcomes compared to pure cataract surgery?
It has, and in many ways, I would say. Well, firstly, I think that I would not say it's exclusive, but in my experience to date, cataracts that are just really tough to get your head around usually either end up with glaucoma or they might go to VR. Um, but your really terrible shallow ACs and pseudo exfoliations and all sorts of things that could go terribly wrong. Not always, and I'm sure that people do manage them all the time, but many a times they get referred to your glaucoma specialist. So it's great to have that experience with all these complex cases. Um, it's easier, I guess, in the sense that it's not the patient's expectations are not quite the same visually. And so the idea is to finish the case successfully, get, a reasonable amount of vision back, and they can wear glasses or whatever afterwards, and they're happy about it. And so in that respect, it's challenging, but equally a little bit easy because the expectations are not quite so high. The flip side of it, of course, is I have pushed myself towards the refractive side of things using trifocals, EDOFs, and all of those as well, where of course the patient expectations are different. So it's nice to be in this position where you can work across this breadth of patients, and really just experience all of that.
Understandably, there's still caution around the use of premium lenses in patients with glaucoma, and particularly those undergoing MIGS surgery. Where do you stand with that?
Well, I essentially I try and just convey to the patient that, you know, if I would recommend it, I would recommend it because if somebody in my family asked for a lens, then I would recommend the same lens to them. And honestly speaking, it just varies so much from patient to patient. I feel trust is a huge factor. I've come to appreciate that even more so here, where my patients are my patients, and whoever I started seeing 5 years ago is still my patient. And you asked about the good aspects earlier on. I think that's one of the great things where it's not a random clinic. It's, as I'm sure you experience in private work as well. These are our patients, and we take this journey with them long term. And as part of that, I think trust is crucial. But and I wonder what your thoughts might be on this as well, is that a lot of things in life are not just the fact that that thing happened, but also the story around it as well, and the story that you create with someone else. And if the patient trusts me that I will look after them, and I have made them feel that I have given them something special, whether it's the lens or the care, then they may not necessarily mind the odd glare or halo or something else quite so much, because the whole package and the whole story makes up for it, because that that's how human psychology works. And so if I feel that somebody's willing to take that journey with me, and they understand that there are significant benefits, for example, in glaucoma patients, yes, you may long term have some downside with contrast reduction and various other things, but what about the next 10 years, let's say, when that patient does not have to wear glasses all the time? Or as someone may have come to me and said, look, I swap 3 pairs of glasses all the time. All of that day to day hassle um, would go away with huge improvements in quality of life. And should we be denying that to that patient who is willing to take that journey with us? So my view is not so rigid on that. Particularly, certainly the mixed procedures tend not really to preclude, in my opinion, premium lenses in any way. They don't interfere with them in any way. But the long-term impact on glaucoma, balancing that out against the significant quality of life benefits in the near future, it's very important to have that discussion and not to preclude these altogether just by saying, well, you have glaucoma and therefore you just cannot absolutely have this. So that's my take on it.
It sounds very sensible, and certainly that doctor-patient relationship is crucial. If you've got good trust there, that's got to be a good starting point, hasn't it? So, Salman, if you needed cataract surgery yourself tomorrow, and I appreciate your a wee ban, and that's mostly unlikely, which lens would you choose to have implanted in yourself, and why?
Well, I've been listening to a few of your other guests, just to try and prep myself for this very, very question, because this one's a tricky one. And I think my answer might so far be a bit out there, but it's based on personal experience, in the sense that my father has been a -1 all his life, and I've never really seen him wear ever glasses for either distance, apart from maybe occasionally whilst driving. And he's in his 80s now, and he just never has had to really wear reading glasses at all. And I've often wondered if, -1 should be the new emetropia really for modern life. Because if you think about it, and the refractive guys will not like this, of course, because there's a lot of -1 ones to be corrected.
They're not listening, don't
And
worry.
that
It's
can
okay.
really but that can really vary from patient to patient. But practically, the other side of it is that I'm -6, around -6 myopic. And when I was in Exeter, in the same year that you were there, I was fully corrected with my glasses, and I started getting a lot of accommodative spasm looking down the slit lamp.
Mm.
And one of the optoms very nicely there said, you should really be undercorrected. So I'm permanently 6'9", and I have been 6'9" in my day-to-day existence for the last 20 years. And I've never noticed it, which is very interesting to observe. So 6'9" is a very happy place to be. But now that I'm getting to presbyopic age, I'm also not getting presbyopia quite so much as others my age. And so I am effectively also functioning at a -1 permanently as well. So I wonder if I would just want to be left with a monofocal, and maybe minus 0.75 in one eye and maybe minus 1.25 or so in the other. And I think I'll just happily bumble along as I always have done. And I appreciate this might not be for everybody, but this sounds to me in my situation to be a very nice, sensible solution.
I totally understand. I'm about minus a half myself, and while there are times when I like my glasses on, most of the time I'm very happy with a very subtle blur in the distance. So I totally understand. However, Salman, you haven't answered the question. So we know your refractive goal. What particular lens would you like implanted?
Oh, yes, of course. So I think monofocals obviously have come leaps and bounds, and there's such nice monofocals out there. Um, I mean, and the Alcon Clarion is great. It's fantastic. The iHands is great as well. And I guess if I went for the iHands, I would then probably go a bit more towards less residual myopia. I think these two would be my top ones. EDOFs, I think I'd be very interested in due time to hear others' opinions and yours as well. Because in my experience, EDOFs don't have the diffractive side effects, but I have come across patients who just permanently have a bit of a blur for distance, and you just can't correct that. And it does make me cautious about EDOFs as well.
Yeah.
I think there's no free ride. I think there's a compromise everywhere.
As previous interviewees have said, you can't change the laws of physics, can you, sadly?
No, no, true. Although monofocal, enhanced monofocals or monofocal plus obviously are doing quite a good job as well.
And in terms of your choice of surgeon for yourself, what would separate a good surgeon from someone you trust to look after your own sight?
Well, honestly speaking, if I know somebody who has, time and time again demonstrated just by virtue of how they deal with their patients that to them, whatever treatment option and how they approach every surgical case is how they would want somebody to look after their own family. I think if that ethos is just naturally embedded in someone, then you can be sure that they will look after you, and that translates into, it could be your 6,000th cataract, but on that day for that person, that surgery is important. It's their eye, and I would look after that in the same way I would want somebody on that day to look after someone in my family, and if I know that whoever it may be, that's how they function on an everyday basis with every patient, then that's the surgeon for me.
You've been very heavily involved in training over the years. What worries you, if anything, about the current generation of surgeons?
So it's not a lot that worries me about the current generation of surgeons, to be honest. I think they have access to, well, firstly, in the UK, the training programs are, despite all the challenges and the ups and downs, ultimately the UK training system remains the best in the world, really. And as you kind of work around different countries, you see different healthcare systems, you really come to appreciate how thorough the training is, and how many huge positives are embedded into it, such as working, much as we don't like it when we're rotating, it's disruptive in many ways to family life and various other things, but you get to work with so many different surgeons and you learn so many different ways of doing things. The breadth of experience is truly remarkable. And in the vast majority of cases, the sheer number of surgical cases is way more than many other training systems around the world as well. So I think that if we talk about the guys training in the UK, I think they have, a lot of things going for them. The access to simulators is is tremendous. I was lucky that at that time when the year I started training, that was the very first year Torbay had acquired, if I remember correctly, one of the first simulator systems in the country. And I remember just going every Friday afternoon and just cracking on with hundreds of Rexes and just trying to figure out how I can make it go wrong and make it go right. And eventually, when I came to actually operate in theater, I already knew what to do, and the pickup was very quick. And this is all embedded into training now, so that's great. The teachers are dedicated. The training systems are very good, so I'm not worried too much about them, to be honest. I think that if they put their head down and just work hard at it, then good results will come off it. Of course, I think that in time there is a decrease in exposure to more traditional things such as suturing and various other things. Although that being said, I went through a lot of my training kind of obsessing about the fact that I'm not suturing enough, only to find that later on I've sutured so much that it's it's kind of made up for it. I don't bat an eyelid on that. And that's just one small example of things. So there can be opportunities that you can make then to learn a whole lot of other things later on as well.
And final question, Salman. If you were starting out again today, knowing everything you know now, would you still follow the same path or would you have an alternative career?
I would actually. I think it's all turned out for the best. I took my time deciding on ophthalmology. I remember just kind of trying out a whole bunch of different surgical specialties and being sad at the end of my F2 year, having missed all the ophthalmology applications because I just hadn't really figured ophthalmology would be for me. And then my last 3 months in F2 were in ophthalmology, which is when I realized, oh, this is what I want to do. But by then, all applications had gone by. So I ended up with a job that nobody else wanted to do in Sheffield and cardiothoracics, which was a completely random year of doing something that had nothing to do with a grand plan whatsoever. But it turned out to be one of the best years ever because there was a lot of surgical experience, and in many ways, I just took it as it was, just to say that, look, this is one year that I'm not going to get back again. I'll just make the most of it. So I had a really good time, learned a lot of surgical skills, which helped me later on in some way in ophthalmology as well. And so, as an example of things, I narrate this as an example of how sometimes things don't appear to be part of the plan, but when you look back on them, you think that, "Oh, it's great that it turned out that way." And then being lucky enough to work in the Southwest where, guys like yourselves had already kind of done amazing things and just kind of stepping into that and taking it from there. I wouldn't do anything differently. Really, no regrets so far.
Good. Salman Waqar, thank you so much. It's been an absolute delight. I hope the current conflict in the Middle East resolves shortly and leaves you
I'm
entirely
sure it will.
unscathed.
I'm sure it will, and we're all hoping for the best, not just for here, but for anybody and everybody who's impacted by difficult situations around the world.
Exactly.
I think we could all do with just getting along and being nice to each other.
Indeed. A lovely way to finish. Thank you so much.
Thank you very much for inviting me. Thank you.